like to introduce Dr. Philip Stricker, who will present his cases next.
Thanks. I presented the results of our patients on the NanoKnife Masterclass 2 days ago, and so this is a denominator of about 600 cases up to date with about 11-year follow-up. But what I thought I'd do is just share with you a couple of cases and some particular points with using irreversible electroporation. So the first one is a person who had an apical tumour, an extreme apical tumour, who then got a recurrence. The second one is a more typical extreme apical tumour that we treated, and the third one was just a tricky case in the anterior zone. So this patient had a PSA of about 10 in 2017, had a clinical T2A lesion and was a Gleason 4+3 actually. After our treatment, we always do a T2 MRI image, which shows hemorrhage. I know Mark Emberton does a gadolinium at this point to look for perfusion, and having spoken to him, I think that might be a good idea. PSA dropped, and the 1-year MRI showed good resolution and nothing much to worry about. 2019, PSA went up to about 10, and then as a result of that, we did a PET scan, and the PET scan did show some activity in that area. We have had a couple of people after IRE where you'll form a cavity and you'll get a false positive with the PSMA PET scan. So just a caution that when you see something bright there, you just have to look at the MRI as well. As a result of that, an MRI in early 2020 showed, as you can see, let me see here. It showed on the ADC an area just here which was adjacent to the area, so clearly I didn't treat that area completely, so that was an adjacent or in-field recurrence. And so we retreated that, and the principles of treating the apex, I always put 4 needles into the apex. I know some people use 3 at the apex, but I always use 4 just for a reliable ablation. And I always make sure that the distance of the active electrode is at least 3 millimetres from the edge. So that way I'm going to treat 2 millimetres outside of the capsule. One of the advantages of IRE that you can treat extracapsular disease. And this was the MRI at the 2-day mark afterwards, showing the hemorrhage again. And PSA started to drop down to 3.7. The 1-year MRI showed retraction of that area and no perfusion, and biopsies of that area in 2022 was all clear, and the PSA up to today has stayed very stable. We then looked at our redo treatments, and the redo treatments, we've had 26 of the patients have had redos, and of those 26, 15 of them have had a durable response with biopsy-proven clearance. Overall, over time, that dropped down to 12, so there was some late recurrences as well. So overall, we actually ended up with half of the patients on a redo got a durable response. And again, there's treatment afterwards with either radical prostatectomy or radiotherapy. I thought I'd just share, I got one of our fellows just to look at exactly what's happened to the redos, because I think the redos are interesting. Over 344 primary REs with a minimum of 18 months follow-up, the recurrence rate was 62 of them, as defined as any Gleason 4 pattern. those recurrences had a redo, and some had some active surveillance and just monitored a tiny little microscopic spot. Some were just Gleason 6, low-grade stuff. This was all recurrences. This is including Gleason 6. And we did redo IREs in 19 patients. And in those 19 patients, 10 of them ended up having a radical prostatectomy, 2 had more than 2 IREs, 1's just been monitored, and 7 of them are clear from significant tumour. But what was interesting was this, when you look at the infield and outfield, the infield ones seem to do better with redo focal therapy, tiny numbers, 4 and 2 clear, although a lot of them decided that, forget about it, I'm going to actually have my prostate out. But the outfield, we had an extremely high 73% recurrence rate after redo in the outfield, which is different to what other people have presented. It's as a result of my general philosophy about infield tumours. If you get any biopsy recurrence on the infield, we are aggressive by doing a repeat treatment immediately, as opposed to outfield, which I think it's more a disease phenomena. This is a more standard case. This is an anterior apical tumour. PSA was about 9.7. And then we treated that with, then this is the PSMA PET scan. We treated that with a nanoknife. This was the IRE. This was the MRI 6 months down the track. PSA fell down and biopsies were clear. This particular was an anterior case, and the reason I'm showing you,
literally covering my area,
is
so
because
that's unacceptable.
We could probably turn the sound down. The reason I was showing it is this is a biggish prostate, and so we put one needle in, and then I was trying to get the second needle in to treat this anterior zone. So what we do, we just re-angle the ultrasound probe. I suppose it's like precision point, and just go back in, and it's much easier to place the electrodes in that extreme anterior zone. And you can see I'm placing them very close to the edge of the prostate, probably only 3 millimetres away is my preferred area. That's the 4th one that we put in. And this is the longitudinal plan, just to make sure that we're in the correct plane. We decide on the length of the electrode, and then the ablation is performed. One thing we've observed with IRE in terms of feedback, the cancer itself tends to stay black, and you get the hydrolysis all around it, which is white. And it's one feedback that you get, not only the hydrolysis, which tells you about the tumour, but the black area, which is often surrounded. So this was the black area here, and as we placed it, as we electrocuted it, I showed this overall picture mainly because you'll see there's some movement of the patient when we're doing it. And when you're doing extreme anterior tumour, that amount of movement is still acceptable because we're giving direct obturator contraction. So you just need to be aware of the movement of the electrodes at the time when you're actually doing it, that type of movement there. And you can see the hydrolysis which is occurring there. So I thought I'd stop with that.
Phil, 2 questions. First of all, how you account for extracapsular extensions you have at 4+3. You're concerned that there's more like a 10 or 20% chance. How you configure your distribution of the electrodes to account for extracapsular extension?
Is the question, how do you change for 4+3 as opposed to a 3+4?
No, how do you technically deal with a high probability of extracapsular extension and you want to treat extracapsular, go beyond the capsule?
So to treat extracapsular, I always place the electrode 3 millimetres from the edge, knowing that the electrical field will go 5 millimetres from the edge of the needle. And the evidence that that works is you can see actually changes while you're actually doing it outside of the capsule of the prostate. And the other evidence is in the 38 radical prostatectomies we've done, you can actually see quite a bit of effect, tissue effect, well outside of the prostate. And the final thing that supports that is in the radical prostatectomies, we have no extracapsular recurrences, yet clearly there were some patients with extracapsular disease. The recurrences are always medial to the treatment zone or an outfield recurrence.
Thank you.
You mentioned, excuse me, you mentioned some strategies that you use for management of extreme apical lesions, like 4 probes, and then making sure that they're 2 or 3 millimeters from either the capsule or the external sphincter. The first case that you showed was a posterior lesion. What strategies do you use in terms of just treatment at the posterior apex with respect to management of the rectum, and then catheter placement following treatment in the redo IRE setting? And does that differ from a primary IRE where a lesion would be in a similar spot at the apex posteriorly?
So the number of redo IREs at the apex are pretty small. Most of the redos are in other areas of the prostate, so you don't have that concern about rectum. In a redo at the apex, I'm more conservative, clearly, and on the area on the edge, I'll still do it 3 millimeters from the edge, but in the scar itself, I'll push it in a little bit further to 4 or 5 millimeters from the edge. It's actually hard to do it because you've got such a scar there and it's so distorted, you almost can't get good contact between the ultrasound probe and the treatment area. So you often are compressing it quite hard. And once you've compressed it and got the needles into the correct space, then I release the tension on the ultrasound probe. So you need a stepper which can do that. And then once you do that, you get a bit of distance from the rectum. Some of the people I've trained have inject water into the area as a safety measure. Sorry, between the rectum and the prostate.
Correct.
Congratulations, Phil. One question. Obviously, you have a lot of experience with the technique, but then I saw that you move the ultrasound during the procedure. How do you account with the parallelism of those needles? That, as we know, they need to be really parallel to make the real effect. Don't you think that if you would be planning with a clear fusion plan before the procedure, this would be perhaps something that will be more easy to learn for the maces?
This is not a case that you'd want to be doing in your first 20 or 30 cases, that's for sure. But having said that, what I've noticed is that I try all the tricks first. You know, I drop the probe down a little bit, and that's the most desperation one, where I actually have to move the angle of the probe to get under the pubic bone. And it's always in a big prostate. And so what surprised me, Rafael, was that when I actually put the needle in and I looked at in the longitudinal axis whether they were diverging, they weren't. And so when I put the first one in, the angle we've changed it to was about 10 or 15 degrees different. And it obviously tracks along that area of the prostate. And whilst it's a little bit divergent, most of the people in IRE say up to 10 to 15% of divergence is acceptable. And then I'll place the ultrasound back into the correct plane again, and so the other two will be okay.
Are you currently doing with fusion, or you still do it like you presented it?
Sorry?
Are you currently doing the procedures under fusion guidance, or you still doing it like this?
Because the answer is all my initial cases were fusion guided, but as I learned that a 5 millimeter margin was inadequate and a bigger margin was important, I started doing regenectomies. And there are cases of a small lesion and a big prostate. I unquestionably use fusion. And in more difficult cases, I use fusion. I don't have a problem with using fusion, but because I generally am going to treat the whole base and mid-zone in a proximal tumour, I don't worry too much about fusion.
Okay, thank you.